But my name is Emily Linklater. I'm one of the OBGYNs at Hudson Physicians. And this is Bobby Ledbury. I'm a nurse practitioner. Yeah. And Bobby is our women's health nurse practitioner. She also concentrates heavily on our menopausal patients, so I wanted her to be here with us tonight. So, small group tonight. If you have questions, concerns, please let me know. It doesn't have to be till the end. But my goal tonight is to go over kind of what is normal, what is natural, but also can be very bothersome, and where we can go from there. So, the big question when I see patients is always, what is menopause? The definition is actually not as important as what we feel day to day as we enter this unknown period of perimenopause, menopause. But technically, it is just a normal, natural event. And it's really when your periods or your bleeding has stopped for 1 year. And obviously that can be confusing because if you had a hysterectomy, an ablation where we burn the uterus, or another circumstance, it can be very difficult to know when we're there. We also feel that true menopause is just the end of periods that's due to your ovaries. So not another health condition, maybe chemo, radiation, but that's just kind of a basic definition. When is it? Well, that's always the million-dollar question because symptoms really start before you really stop bleeding for a year. We do know that there's natural. What is that? That is just your ovaries decreasing estrogen and other hormones. There's, of course, medical, if your ovaries are removed, that example of chemo and radiation. And then there's premature, which happens before the age of 35, and we won't go into tonight, but that would be another reason. So in reality, we have definitions. In reality, we can always pull textbook answers, but what it comes down to is really what's going on day to day and when does that happen. And so I thought this was pretty, actually Bobby agreed, was pretty characteristic of, what are these symptoms? Really the bleeding, although we'll go through it, is pretty low on the list of what we see women for. Lighter, more irregular periods aren't necessarily bothersome. So the interesting part is when we talk about menopause, the actual age of menopause has stayed the same. Somewhere around 51 or 52 is natural menopause. So once again, that's what we consider you've stopped bleeding for an entire year. The one part to remember, though, is we're living longer. So actually, the amount of time that we spend with symptoms in these menopausal years, or even perimenopausal, are greatly lengthening. Once again, it's usually not so much about the bleeding, but it's about those changes. Why do the changes happen? Well, we spend a lot of time on the uterus and ovaries, but actually there's estrogen receptors, so estrogen, the hormone that is produced by our ovaries, all over our body. So when we're in our reproductive years or our 20s and 30s, and estrogen is high, then it's affecting all the different areas. So brain, heart, liver, and that's why a lot of the symptoms such as brain fog, mood swings, they're not just all in our mind. Those receptors actually are not being fed. So that's kind of like a door that's open with estrogen, and then that makes you not have the mood swings, not have the, insomnia, and now that door cannot be open because estrogen is not there, or is there in very low quantities. So what are the symptoms of decreased estrogen? One we always talk about, of course, is hot flashes. These are the sudden, I'm taking off a sweater, I'm feeling hot, kind of chilled, and then they're going away. Mood swings, changes in sleep, even kind of that living in a brain fog. The hard part is, I know you see that's under short-term symptoms, but the really hard part is the fact that some of the symptoms are gradual. So a lot of women come in and say, you know what, really, I think I've been feeling crummy for about 1.5 years. But it's just now that I realize, yeah, I'm not sleeping. We also talk about changes in the vagina and the vulva, the area outside of the vagina. And then, of course, we talk about long-term. And as we live longer, this really comes into play. So that's heart changes, osteoporosis, thinning of the bones, and then eventually, the cognitive decline or Alzheimer's. So This is what Bobby and I think is a great representation. So premenopause, once again, this is usually before 35. You could be argued into before 40, depending on what study you read. But the nice kind of up and down graph, that's what your hormones are doing. So they're very predictable. You know, maybe you have symptoms around the time of your period the week before, may have some bloating, mood changes, but they're pretty predictable. You would say, yep, week before my period, these are the changes. All of a sudden we hit the perimenopause. So as a reminder, perimenopause is just you're having changes in the hormones, but you have not stopped your periods for an entire year. And that's a good example of just what they're doing. They're all over the place. And then, of course, when we hit true postmenopause, then the hormones have consistently been low. So then we talk a lot, okay, going through the symptoms, what can we do and even why are they happening? So we talk a lot about vasomotor symptoms. This is really the hot flashes, night sweats, you know, what we call flushing. One of the hard parts of perimenopausal and the menopausal periods, so really just greater than 35, is knowing, is this a different health condition? Are we missing thyroid? Are we missing Lyme's disease? Or is this more of the natural process? And what we don't want to miss is another health condition, obviously. But hot flashes should really be recurrent. So if you're having one a year, then we say that's probably not extremely bothersome. They should be transient, just meaning you should not be wearing a tank top all day. You know, it should be sweater to tank top, back to sweater. We know that 75% of women, really greater than 35, will have hot flashes. It's an actual increase of your body temperature. So it's not in your mind, it's not an area that's, you know, can be controlled. It's an actual increase, similar to if you had a fever. We start increasing temperature. And as always, we should treat based on the symptoms. So symptoms, well, that's always, you know, the important question of where to go there. Just to talk about periods, you know, 35 and older, 40 and older, really periods should start becoming more irregular, should becoming lighter, and that is as the estrogen is decreasing. If periods are becoming heavier, closer together, longer, then we really need to do a workup, some labs or ultrasound to be sure we're not missing a different concern. So when we talk about what a hot flash is actually due to the hormones. Your body temperature increases, you get more blood flow to your skin, and then you start sweating. All of a sudden the sweat does what it's supposed to and cools you down. So really when we talk about, is this some perimenopausal, menopausal hot flash, that's really the phase it should go through. Moving on to different symptoms. So vaginal symptoms become very important. And for no other reason than a lot of times hot flashes will be present for 3 to 5 years or even up to a decade and then lessen. But vaginal symptoms such as vaginal dryness, kind of itching, pain during sex, that all kind of persists as time goes on and even can worsen as time goes on. And that is because there's actually, we like to say a thinning, but it's actually an atrophy of the vagina. And I'll show you a picture next. So when you have high estrogen, you have those reproductive years, it's the picture on the left. So we have kind of that bumpy, rigid, I always describe it as, you know, the inside of my finger where you have, you know, lots of little bumps. That's good for friction. That's also well lubricated. When you go into a low estrogen state, then all of a sudden what we call them as an atrophy or just a thinning. Obviously that can cause a lot of symptoms. It can cause discharge, bleeding, and definitely painful sex. We also, though, it's not just about actual sex. We can start seeing a decrease in sex drive. We do know that as testosterone, so that male hormone that's produced from the ovaries, as the ovaries decrease their hormones or stop working, then that testosterone does go down. Testosterone is linked to desire in women, and then also as pain can increase, then desire can go down as well. Any questions kind of up to this point? So that's kind of an overview of what is normal. Doesn't mean you have to live with it, but what's normal. So then really the big question is we go into management. And if you've looked on the internet, read any research, the hard part is what actually is the management. We throw out words, compounding, bioidentical, estrogen's bad, estrogen's good, where do we go? So I just wanted to put out a few just definitions. So remember, hormone therapy is just using hormones that you're taking somehow. It can be by mouth, it can be a cream, it can be vaginal. Estrogen therapy is just estrogen. Women who do not have a uterus do not have to have progesterone in menopause. They may decide to because the symptoms, their symptoms lessen with it, but they don't have to. So we just call that estrogen therapy. Estrogen, progesterone, which is spelled wrong, therapy is obviously using both. Compounding, so when you hear people compounding hormones, these are just hormones made by a pharmacist. Okay, they are combined in a pharmacist lab and they're available. Bioidentical hormones, these are really man-made hormones, so a scientist made them, and they're trying to mimic our normal hormones. So that's where a lot of confusion comes between compounding and bioidentical. So what do we know? I'm sure everyone has heard estrogen's bad, estrogen's good, estrogen will increase stroke, estrogen will help you prevent a heart attack. The WHI study that's come out probably about 20 years ago really changed estrogen for us. That was that big study that said everybody probably should be off estrogen. We are increasing heart conditions in women. Since then, as you can imagine, that study's been dissected. Also, many more have come out. So really, what do we know? We know that we should consider symptoms first. If symptoms are bothersome, then we need to have a discussion about those symptoms. There's no reason to live with bothersome vaginal symptoms, painful sex, hot flashes that are interfering. We also know that if you're having like 1 or 2 hot flashes a week, it's probably manageable, and that there would be maybe no reason to use a medication. But what we know is risks are very low based on age. So women who are taking hormones in their 40s and 50s and early 60s, the risks are low. In fact, lower than if you ever took a birth control pill to prevent pregnancy. Risks do start increasing into the 70s. Not that you absolutely have to be off them, but it becomes a bigger discussion with your practitioner. We also know that how you take them can matter. So by mouth, anytime you take a pill by mouth, it goes through the liver. A lot of times because the route is through the liver, we do need an increased dosage versus wearing a patch and using cream. We know timing is important. So when I meet with women and they are saying, yeah, still having irregular periods or periods here and there, but my symptoms are horrible, then we know that they're still in the early phases. When I meet with someone that said, yep, I'm 85 and I went through menopause 30 years ago, but I'm getting hot flashes, that initiation time is riskier. So that's just basically based on age or based where you're at. We know that breast cancer risk can be increased, but it usually isn't until over 5 years. Some studies even show 8, and it's with the progesterone use, similar to the studies that are out with the birth control pill. And we know that actually estrogen alone, so for women without a uterus, can actually lower breast cancer risk. So as you can probably tell, there's not a lot we can hang our hat on. We do know, though, that there is not a reason to suffer through perimenopause and menopause. However, it's not all about medication. There is a lot of lifestyle changes that women can consider. Exercise, avoiding caffeine and alcohol, maybe even changing just how you keep the bedroom at night, so not using a heavy blanket. We know that there's a lot of options for reducing painful sex and even dryness, using moisturizers, continuing to have regular intercourse or regular sex, continuing to use lubricants can sometimes bridge the concern between no medication and medication. We know that there isn't a lot of research, but there's some promising research that herbs such as black cohosh, St. John's wort could help relieve symptoms. We also know that there are options for over-the-counter hormones, melatonin if you're having sleep problems or insomnia. There's topical progesterone. The only concern with the over-the-counter hormones, such as topical progesterone, is they are not necessarily following FDA regulation because they don't need to, so there is a concern of how much extra hormone you are getting. So the big question is always, should I go on hormones? I meet with women many times a day and they say, should I do this? Should I not? We know that if you are having life-changing symptoms, it should at least start the discussion. Because as we live longer, then the symptoms will most likely persist. Of course, we need to make sure that you have no contraindication, meaning like breast cancer, abnormal bleeding. And it's important if you're newly menopausal. Newly just being most likely in the last decade, versus once again, menopause was 30 years ago and now maybe 5 and having some hot flashes. When should you not consider it? Well, if you are having those 2 hot flashes a week and you are saying, okay, intercourse was painful, sex was painful, but now lubrication is helping, then continue on that path. You do not have to use estrogen to preserve a concern in the future. Also, we really need to target what the symptoms are. If your symptoms are hot flashes, there's one option of treatments. If they're vaginal only, then there's another option. So we can really start targeting different concerns in the body. Obviously, any kind of contraindications and late onset. So then we also go through hormonal therapy. What is options? Of course, what's been out for a long time is estrogen pills or estrogen progesterone. Those were really the first medications that were studied. We know that patch is out. So the patch is no longer obviously taken by the mouth. It is put on the skin, so it's avoiding that liver. We know that there's pellets and cream, gel, and sprays. We know that there's just medication for the vagina. What I mean by that is estrogen, progesterone, and even testosterone cream. Estrogen can even come in a ring or tablet to be put in the vagina. Then we know there's some other, non-prescription medications and other medications that are combining kind of estrogen, but before it's converted to estrogen. And we know that there's non-hormonal options. So it's not all about estrogen, progesterone. Studies repetitively have shown that if you're low risk, that is an option that most of the time works the best, but there's other options. So antidepressants, of course, gabapentin and clonidine, all options if you're not a candidate. And I wanted to include this slide because this was probably one of the bigger studies that came out that said, you know what, maybe if your symptoms are persisting, we should continue or consider a different route. So this good old, you're taking Premarin, which is the old drug's name, may not be the best option, may not also control the symptoms as well. So I just wanted to include these slides. I promise I won't go through them all. Of all the options that are available, not including compounding. That's the end. Questions or concerns?
The thing I was going to add too is that one of the biggest questions I get too is how do I know when I'm going to go through menopause or just have an idea? And they do say that your, first check your relatives' history. If you have obviously your mom that has talked to you about it or is still with you, or an older sister, and it really does still hold true even with consideration of all the other factors in our lives. It really truly does help to predict it. And then also with the temperature, I always say this, explain it in this way too, is that you just have, the threshold of when you sweat versus when you get chilled also gets squished a little bit when you lose those hormones or when those hormones are kind of maybe erratic. And so again, it's not in your control, but to understand it is a normal thing, and that you do have some options if that obviously is impairing your day-to-day.
Yeah. And the one thing Bobby and I didn't touch on tonight was testosterone. We had debated a lot to whether to put it in the presentation. You probably noticed early on when we talk about decreased sex drive, which is a concern that I see with many women, we talk about, well, there is a decrease in testosterone. It is a drug that can be compounded, so once again, made by a pharmacist. The research is unfortunately limited in the United States. However, in other countries is widely used, testosterone is, but that would be, a consideration. So, I hear a lot from patients, we kind of go down this spiral of just saying, okay, I'm going to forget about the sexual drive. I'm now going to just live with the hot flashes, and there are options. You have anything else to say about testosterone?
I was afraid of it.
Yeah.
As a provider, I think what happened is that in post 70s, I think of Johnson, was it Johnson or Johnson? I can't remember who it was, but they were starting to really take into account, oh wow, hormones, they're gold, they're great, maybe longevity, prevention of cardiovascular disease and everything. And I think then testosterone started to become more popular, but then obviously once you moved to the 80s, 90s, more press with estrogen, progesterone, but then the Women's Health Initiative study just kind of brought everything back down, in terms of the popularity, the discussions, of the research and all of that. And so I do feel that now testosterone is starting to kind of get its I guess there's a headway coming with some hopeful interventions for women who are symptomatic, whether it be sexual desire, but also vaginal dryness too, that they may not be a candidate for estrogen therapy. So I think that's to come. I think Dr. Linklater has used it a little bit more than I have, but I am starting to become much more open to it.
A lot of women don't realize that bioidentical can still be FDA-approved medication, and that's what we always talk about versus, going down the Target aisle and picking up like Estrogen or anything. The big question is how much estrogen is really in that progesterone.
So then, you have the option like in a patch. There is some vaginal cream. There is the suppositories for the vagina. Obviously, the oral pills are an option as well too. The gels, the sprays. There's a Eva Mist that I don't use a whole lot. I think the price point is pretty high, but those are options. And I think we're starting to see more and more insurances being okay with covering these transdermal products, which seem to offer a little bit more of a continued delivery system and hopefully safer and more effective at treating symptoms too. So the difference, as Dr. Linklater has pointed out, is that you can absolutely still have these as options that you can get through your insurance. Again, all depends on what your deductible and what your copays are and all that, that are regulated, that the FDA keeps tabs on these manufacturing pharmaceuticals that are making these products. But we also appreciate, especially as clinicians and when we're sitting down with the patients, that there is the compounding option. I would highly recommend that if you are considering doing a compounding option, and usually you are saving a little money because you're not having to pay all the overhead or help with the overhead cost of a medication, that you have a reputable place that you go, that you understand, if you will, they stand behind their product, and that your provider is also in agreement with that choice of compounding pharmacy.
We don't have to test to know if you're in menopause. I get asked that question frequently at annual exams because really it comes down to symptoms. It may be fun to know, but there's really no value as far as testing to see if you're in menopause or not. There's a lot of hot research or hot topics out. Should we be following saliva tests from the mouth on determining your estrogen? But really an important part to start is just if you're having symptoms, let's try an option. Sometimes the more refractory cases when we talk about actually testing. But there are a lot of organizations that say, yeah, come every day. We'll test your saliva, tell you exactly how much estrogen that you should have. And remember, you don't need estrogen. It's a natural process. But you may need it for symptoms, but you don't physically need it. When I meet with patients first, I often tell them this is going to be a little frustrating because what we're going to talk about today seems very motivating, and then you're going to perhaps call me in 6 weeks and say, listen, this really didn't sound as good as it did in your office, or I'm having absolutely no change or any change at all. And as, depending on which stage we're in, as we decrease estrogen, then we need to make changes as well.
Comparing like stent, the success of stents in terms of obviously the coronary artery disease, and how lifestyle alone can actually just be as effective for a person who is considering stent placement. And I was like, wow. And aerobic daily exercise they've always looked at in terms of, especially important during the menopause transition. Clean eating, lots of fruits and veggies, lots of color is probably the biggest thing. Limiting dairy, limiting carbs, they throw all that out as well too. It's probably of all times an ideal time to consider, really cleaning things up as well too. I find that helps quite a bit and help with temperature regulation a little bit, but also make you just feel better.
But in a good way. Luckily, we're moving away from the WHI that was everyone should be on 0. And even 10 years ago, I remember saying, I don't know about that testosterone. Even when I would see women from other countries who were prescribed testosterone, by physicians in those countries, I'd be like, oh, we absolutely don't do that here. But it really comes down to it's very individualized. So if you do have the 4 stents in your heart, then no, unfortunately, estrogen is not a good option for you. But most women who are symptomatic are not at that age. So the WHI study, which kind of sent us into this downward spiral, the average age was actually in the 70s. And so as other studies have gone back and looked, unfortunately, it would have been nice if the average age was in the 50s, because that is the most common 40s and 50s to treat women with the type of hormone.
This is kind of a general question.
Oh, sure.
So overall, do you advocate for like hormone replacement or birth control? And if so, what determines whether you use one or the other?
Yeah.
Or do you advocate more lifestyle changes?
Yeah, good question. A lot of it depends on the individual. So for instance, if I meet with a patient and her BMI, that body mass index, is 40, and we talk about sweating, we talk about, okay, there's weight gain, and maybe we go down that route first. If I'm meeting with a woman and she's like, yeah, my hot flashes are not ideal, but they're okay, but I'm having vaginal symptoms, that it's pretty quick to jump to like vaginal estrogen because it's not systemic, so it's not going through your blood system. It just really depends. A lot of it is a patient's outlook. I meet some women that are saying, you know what, yeah, I have not tried yoga, I've not tried exercise yet, I'm interested. Other women say, I'm pretty healthy, I'm pretty active, I know I'm not doing yoga or treadmill every day, but that's just not going to work for me. So it really comes down to, there's risks and benefits to each option and how they intervene. But the important thing to remember is you don't have to be on hormones. They do not preserve anything for the future. All I mean by that is even if you have osteoporosis in your family, yourself, we do not give you estrogen to try to protect it, even though we know it's protective. There are other options. To answer your question about birth control pills, that's always a hot topic. It depends on other risk factors, but in reality for my patients, I usually, if they're happy with the birth control pill, they feel like they're controlled, they continue it on. Really, a lot of studies show that less than 55, without a history of heart attack, without a history of obesity, all the above, or actual obesity, then it's reasonable. But I know a lot of practitioners will say, really, if you're getting above 45, even without contraindications, maybe we should switch you over.
It's listed as a contraceptive, but it's actually kind of like a hormone replacement product with synthetic progesterone, which is kind of in between a hormone replacement product and birth control pill that actually works fairly well. I haven't used it a whole lot, especially with the women who are in the perimenopause position that are having irregular, heavy menstrual bleeding.
When birth control pills were not generic, when everyone spent $50 to $100 a month on them, the pharmaceutical companies were really competing. And you probably remember that. Ads were everywhere. This one has better skin than the other, even though that one pill just got FDA approval to be able to say that. And so what we learned is you can decrease estrogen, but sometimes it increases your risk of pregnancy, but it actually works well in your upper 40s, early 50s, because we maybe don't need quite as higher dose. Because the chance of pregnancy is lessening. So sometimes that's an option where I switch women to we call it a 20 mic pill or just a smaller estrogen pill.
One other question that I had was, so some of the thing that I just noticed the last year is, I've seen some things about vasomotor symptoms, is I've developed vasovagal. Is that part of the vasomotor?
Is it when you're, do you have hot flashes at all?
No.
Okay. Is it related to any food, diet, exercise?
Nope. happens right at when I have my period. It's like that day or right before the day, and it's been so severe, like I've gotten into the emergency room because I've pretty much passed out from it.
From the drop in pressure.
Yeah.
Yeah, but I was just reading about this the other day. It's definitely not a direct relationship. You have your nervous system and then you have your hormonal cascade, and then we really look at, it's the shift of the hormones that seems to just kind of disrupt, that's what kind of brings us all on. And so there is possibly an association. It kind of follows the same pathway as like a condition called cyclical vomiting syndrome, but also, what is the other one? Abdominal migraines, actually. And there is this hormonal influencing factor, but when we go to, the thinking is you could try to balance out the hormones by giving you extra hormones to try to see if that helps. But I don't think that there's a lot of information that's supportive that it does. So to answer your question, I think it's definitely an association, but it's not as a directly linked association. It'd be easy to fix with hormones, is what we like.
Yeah, and the reason I just went back to this slide is because, in the reproductive years, our 20s, early 30s, our hormones are going really up and nice, beautiful. But as we enter, 35 and above, our 40s and 50s, then they're more radical, even though you may not be seeing that in your bleeding yet. And so that's why you could be seeing the changes. So the hard part is, it'd be amazing if we could come up with a test. I just said, come on in, I'll just draw your blood and say, this is what's going on. So that's when, we could consider trying hormones, but usually it'd be more of elimination of the period. Great.
Riding the roller coaster ride,
Yeah.
as I like to say. You don't know if you're going to go up, you're going to go down, how long, quick will it be over, all of the above. I don't know about Dr. Linklater, but Estrogen has been around for 30, 40 years, and it is something that is accredited by the North American Menopause Society as an option for the woman who is wanting to try something for their mild, maybe to a little moderate symptomatology. It can be effective. The one thing, as Dr. Linklater said, is you just gotta, be cautious. Don't be over bombarding yourself with a whole bunch of different herbs and then taking estrogen on top of it. But just the same, it has been around for a long time. They do have now the different options, like they have one for mood, they have one for sleep, they have one for, I'm sure, weight loss, right? And that's where it starts to get a little bit more stuff added to it. And again, I always like to say, what are you thinking? What are you currently on? We can talk about these things. It's just that it gets a little bit, there's a lot of different things that are over the counter, let's put it that way, and it can be hard to differentiate which one is going to truly help you or not, but it is an option.
And Bobby made a good point. The North American Menopause Society, that's where most of the research comes from. But they do have a great, you just Google North American Menopause Society. They have great options for patients. They have a lot of wonderful fact sheets, wonderful resources. And they are, the accreditation for practitioners as well. So, any other questions? Thank you for coming. I know it was snowy. I know it's December. It's 2 weeks before Christmas.